Well, this is the moment you've all been waiting for. You can leave now. No, this is the moment where we can ask questions of the presenters. I think there's an unfortunate situation where you couldn't ask as people had presented their work at that time, but I think hopefully you've stored up some questions, and we'll do the best we can to answer them all. Everyone has supplied some contact information, so you should be able to reach people after we're through today. But let's open it up.
I'll start.
Seddon.
I have a feeling that something that is in the back of people's minds, if not in the front of it, and it's certainly in mine, is that as a clinician, which is what I am, as prevention providers, I perceive that people have heard so many things that they'd like to implement tomorrow. We are in the healthcare transition as of July 1st, I believe, in New Hampshire. We are going to have many, many more insured patients who have the right to substance use treatment. And we think reflexively we could fill those gaps with all these wonderful technologies that we heard today. The treatment capacity that isn't quite there to match the need, and now the insurance coverage. So how do we identify currently available programs that we can begin to integrate into our practices?
Well, I just wanted to, yes, I think everybody has that question, and I wanted to just mention a resource that we're developing on our CTBH website, which is a program review. So you'll find at c4tbh.org under Technology and Action. It's a program review where we're actually going through the empirical literature and providing a summary of the evidence base for some of these tools that are out there. Now, whether they are all in a commercial format, I can't say that. I can say they definitely are not all in a commercial format, but some are. And they certainly could be likely used in a convincing way in research projects, capacities that may help to meet some needs and collect some data at the same time. So that's one response, but it's a really good question. Anybody else?
I guess I'd just say, based on the reviews that I've seen in the past few years, I'm also a little concerned that we're maybe not ready, that maybe we don't have the level of efficacy that we have for other behavioral interventions that it's appropriate. I mean, there may be a few that there's some, a single or a couple very good trials, but even the most well-studied ones, there's really not that level of background.
I just want to say that one of the principles that our MySafeRx program was designed around was the idea that people do need a clinician, and they do need people they can connect with, and yet technology can help augment that and make that clinician more effective and extend the reach of what we can do as providers, not get rid of the providers. And so I think that there are certain technologies that can be good adjuncts to that clinical practice that you're talking about, but I don't think that you can just kind of say, well, all these new people are coming on, let's just give them a technology. I don't think that's what you're saying exactly, but so, I think partnering and adding some of these things that can extend and make some of the work easier is the way to go.
Joe?
I had a couple of thoughts about that, and especially from my own space with having right here in old, actually, yesterday, I sent a text to one of my kids, and my other three kids wrote, "Dad sent a text." It's like a new era. And so, what I mean by that is I'm a digital immigrant, and they are all digital natives. They live in this world, and so one sort of thought that I would have about this is to engage them, is to educate them as consumers into this world, and to work with schools and kids, on, in your future of trying to stay healthy, you can use your you can use the stuff you know how to use, better than your parents do anyhow. And that might be a place to work. The other thought I had about this is, I would suggest you look at it as a disruptive technology, not as, an adjunct or anything like that, This is like doing coronary bypasses and all of a sudden discovering that angioplasty works better. It's disruptive too, And so I look at a lot at Christensen's stuff, and also maybe try and partner with Tuck, with the business community about how do you get a disruptive technology into the world. And it may not be actually systems that are on fee-for-service models that want to adopt this. It may be CVS, or it may be, I don't know, some other places that might be good partners that we're not thinking about right now. And maybe Tuck would have some ideas about that, about getting this stuff that works as well as the clinicians, it looks like, in a lot of things, into the world. And somehow not embarrassing the clinicians, but sort of having them, how they embraced angioplasty and how they embrace, the disruptive technologies that have taken over medicine. And all of a sudden the wave is coming, and the kids know how to do it, and, maybe even medical students would be good to try and teach about it, so that the future has more of this in it than, they're the early adopters and the early majority and stuff, not the laggards. It's, a lot of the older people that are laggards, so.
The first thing I'll say is that's why these two are up on the stage instead of just all the older folks. So, we have our younger colleagues to assist us that are digital natives and grew up in that world. So, the other thing about the idea of disruptive is actually some potential very positive effects too. Is if you put empirically based treatments, you force clinicians and other treatment providers to have to know that stuff. And there's a pretty substantial history or set of research that suggests that in lots of settings, there's more chatting going on than actual treatment. And so if it's more vital that when you see your clinician, you're getting something valuable, then maybe that'll prompt that. If the patient is able to say, well, I did, the triggers and I did the da-da-da-da-da, so tell me how I can deal with this situation, the provider has to know something.
But just to add to that, I think and to echo what you said, Zev, that there's always the need for, you still need buy-in from providers, because even if it's a standalone kind of tool, you need, they really can be your champions in terms of recommending these things as well, but also to sort of promote that consumers can also be at the forefront of informing providers about how they're working. There's some anecdotal data, that actually, with somebody even from our shop that uses these apps, just these commercial apps, in her, around keeping track of, her emotions and all that. She uses it, and she brings it right into her therapy office. And her therapist is like, oh my God, what do you, how can we integrate and use this? So that's a great example.
And they'll say, whether it's diabetes or whatever, they'll say, how do I give you this data? So that the therapist then has potentially multiple things.
There's a statistic that says that it takes 17 years to get 14% of innovations into the hand of the public in terms of healthcare innovations. And on the surface, that sounds abysmal, like deplorable, like a broken pipeline of some sorts. But on the other hand, it might not be such a bad thing, because it might ensure that the kind of things that do ultimately make it through are effective and safe and so forth. And I was thinking about your comment, Brent, that are these technologies, are they effective enough? Or is it a case where demand is outpacing development and testing, if you will? And I guess I wanted to get your perspectives. As developers, how do you sort of balance what you know about these interventions and then kind of getting them out to the field? How do you manage that?
That's why I'm still developing. So, but I think that we do have some models that are absolutely further along and are moving, towards true effectiveness evaluation. And I think that that's part of the reason that the integration with the implementation, I think, is important, so that we know which factors will ultimately be important as far as how we can get something to be out there and be effective. I think that the actual effectiveness of even our best interventions, whether it's CM or CBT, are really good compared to nothing. But we've got a lot of room that we can still improve on. These may be a way, technologies may be a way of increasing it in some areas to push that envelope. But we need to work with things that we know are truly effective to begin with, I think.
A comment, I think this is on, a comment from a guy who's even older than Joe, an old physician. I really appreciate the discussion or the comments about evaluation, because so many times in medicine we've seen innovation that everybody jumps on the bandwagon for and thinks it's just fantastic, and then you find out after a little while that it's really no better than what you had before, and you've wasted a lot of resources, and we have limited resources. And there's so much survey bias. I listened to the talks this afternoon about where you had evaluation by participants in studies as well. And I really have to compliment the presenters in how careful you were about those evaluations and not saying, oh gee, they thought it was fantastic, because anytime you try something new with people, anytime you make any intervention, anytime you ask questions, we know about push-pulls in politics, how you get the results that you're looking for just by asking certain questions. And since resources are so limited, I think it's really important that people adhere to the kind of principles that you have. I really applaud you for that.
Thank you. Kathy.
Thanks. Just reflect on what Mark mentioned earlier about isolation and connection. And a few times in our IOP group, it's come up from patients when another patient wasn't there. Let's text them. Can we FaceTime them now? We've had patients say, do you mind if I Skype, because I'm not going to be in group, but can I Skype into group? And here I'm like, geez, I don't know about all that. I know, obviously I FaceTime and I Skype, but we're walking into a whole new territory here. Can we put that one on hold? But they're coming up with their own ways. But the point is, they're not looking to stay, they're looking to stay connected to the group of people in the room. And so I think, I like the idea of adjuncting a lot of this, because they're already really doing it. They're, so-and-so isn't here. Well, let's try to get them on FaceTime and see where they are. Maybe not, but they want to stay connected. So just ways that patients can stay connected to one another in a way that feels good for them outside of the setting as well. I don't know if there's thoughts around that.
Well, I would just echo just some of the privacy security issues with some of the technologies. And
obviously, we're not doing it. But.
Yeah, and I think that's where we could do a better job at sort of disseminating. There's work being done around that sort of stuff, but really disseminating and providing information about how to protect yourself with technologies is really important.
What you're saying just made me think a little bit about how, in recovery people talk about the people, places, and things can be triggers for relapse or for use. And I think it goes the same way that when you develop a recovery community, those people become triggers for that day to remind you about, your recovery orientation. And that's why this idea of kind of daily face-to-face contact, I do think that when you start to associate people with recovery and you're having that connection with them, that really gets someone in that mindset for that day of having that day be about recovery. So I think that connection is important.
I'll put out one other thing, which is actually the relationship with the technology itself. So, and people, we all have it. We have some connection, a feel for our phone or whatever the technology is, and there's some, we have emotions with everything. So we have relationships with our technology too. And I think that when we think of all the little bits that we put to make a system what it is and the way it looks and the qualities, we're trying to highlight an opportunity for there to be a positive relationship with that. It may be that we're at a stage where we can start actually measuring the extent to which people feel like they have developed a relationship with something they know. And there actually have been some research on that, of developing that evaluation of that, just like it is with a therapist. So I think it's only one relationship, but it can be an important relationship as well.
I actually had one question when you were doing your presentation that I wanted to ask, if that's okay.
I do. Actually, about integrating a social aspect into programs, whether that's web-based or mobile-based, I would caution about building out something like that, because you need, a moderator. You're not able to control what's said, whether it's like a chat room where people can collect, that you're going to have to monitor what's being said, or whether that's conversations that are happening through the program. So that's something that should definitely be a consideration.
So if I may, so one of the things that came up for me when you were talking was that a large proportion of the people who used your service with their phone, they used it when they were using or had just used. And you were talking about using cocaine users, and I was thinking about how when people use cocaine, often the cues that are associated with that actually kind of become part of things that can then lead to trigger use again. And I was thinking then about how a lot of the patients I've worked with actually are very connected to their phone, because their phone has all the numbers of all their dealers in it. And then I was thinking about how in a residential program we often limit people's phone use for a while to be able to try to disconnect that. And so I guess I was just wondering about, these devices are so integrated. They both are integrated in a positive way, but they also very much have the same triggering potential or cue potential to go to the other way. And so how do we deal with that? And do people have like their blue phone, and they also have their red phone, which is like their bad phone or something, and they just kind of pull them out when they want to do their good thing versus their bad thing? And how do we think about that?
And they have a relationship with each. Yeah. I unfortunately, I didn't ask to find out. That would have been interesting to find out how recently it was that they had used, if it was just past, just minutes ago, or whether this, when it was. But the, time since the last call you made, have you used, I think does represent that too much time. And more specification would be a way of starting to get some idea. Are people, using because, or calling and using some system because they don't want to use again, or are they, are they using this as a protective technique, or are they, it'd be funny to call the, that thing, or to do that after they're already high.
And I guess it also just made me think about how people also can start to develop. Oh, time to go? Oh, sorry. Okay. I think people can develop kind of obsessive compulsive tendencies, and I wonder to what extent people that become frequent users are kind of substituting their addiction.
Questions? Al?
I'm just trying to talk loud. I'm a science guy. Question of implementation and red race. When are we ready for red race to implementation? State you know, that is quite a quandary or paradox. It's like we have no criteria for that. And most medicine is not criteria. How many good studies do we need? Empirical based on this based on empirical principles, and you know that's the way it's works. Given the state of treatment as usual, in addition to that, or after things being delivered, don't have that time. How far do we have to go before you can bring it to the agency and say, yes, this has enough data? I don't know the answer to that, but it's kind of, sometimes I say, you're rolling that out, you ain't doing anything about it. And the other hand, I think, like, this guy is better than that. And so it's quite a,
I think that's a great question, and I wonder if it means that we need to change our research paradigm a bit, and maybe think more, draw from sort of industry models a bit around, so that maybe we should be implementing earlier, so that we're actually optimizing implementation of what we think is, you know, here's what we've got, and let's implement it and optimize implementation, and maybe then we move to the, you know, the larger trials. And I think the technology is great for that, just being able to do demonstrations. And really, if a well planned out demonstration with really good metrics behind it, you can get a lot of information.
and they hear something that somebody teaches somebody, they can increase it more, they come back, and now their groups are all data, no data, that's kind of the way the clinical field works. And then all these folks are all creating empirically based treatments, do a bunch of tests, and then still have to come up with some barriers that really doesn't exist in the clinical world, except it's always self-imposed.
But that almost, I mean, that really emphasizes the point of that, you know, providers want to be involved in developing the intervention. So if we can get folks involved early in developing these things, it really can help maybe build buy-in so they have ownership. They feel ownership.
So I was thinking this on a different point, because I don't think Alan's question is answerable at this point. But I was thinking about iTunes. iTunes has, you know, rock music, jazz music, country music, and so a lot of the interventions that you were talking about were fairly diagnosis specific, right? And I was thinking about, you know, Peter and Greg King, that are primary care physicians that are thinking about ways to integrate behavioral health, you know, as a kind of a peculiar subspecialty within the context of their workforce, their workflow, to improve the care, comprehensive care of their patients. So I was wondering if you've given much thought as developers to more kind of broad spectrum transdiagnostic approaches, because your medication tool could conceivably be used for antipsychotic medications, antidepressant medication, mood stabilizers, what have you. It's interesting. CBT is, you know, wildly effective with everything from sleep to sexual dysfunction and drug use. You know, the kind of things that you were talking about, Rachel, are also kind of broad spectrum approaches. So I wondered if you all were thinking about things along those lines.
Certainly having a holistic approach to treating the whole person, I think, would be wonderful to have. And starting off with kind of a general health risk assessment, looking at various aspects of one's life, and building a program that looks at kind of all the areas that are problematic, and building a program to improve generally your life. I think would be wonderful.
Related, I think we can actually use the systems we have and find out what people tell us they use it for. I mean, a lot of the people that used my system, I don't know if they'd say it was always used for drug abuse. It was used because they were stressed. It was used because they, felt X or Y, couldn't sleep.
I think I want to respect people's times. It's a little past the top of the hour. Is there any burning desire, final question?
It's probably a good place to end, Mark.
Okay, thank you
Thank you all so much for coming. It's been a great day.